All right, welcome to the Board of Health meeting for July. I'd like to call the board to order, and we have some approvals before you. Thanks for joining us this morning and the technology and the Silver Beach view. So we have minutes that Kim graciously sent out. May I have a motion for approval of the minutes?
So moved.
So Dr. Edwards moved, and a second.
Second.
Was that you, Joe, or was that you, Dwayne? Sorry.
Either one of us, I'm fine. I don't know.
Okay, so Dwayne second. Any discussion on the minutes? All those in favor?
Aye.
Opposed? Okay, motion carried. I don't see Lisa there, so for the vouchers, is there anything unusual, Nikki?
No, there is nothing unusual, and Lisa is out today. There's nothing unusual in the vouchers, all business as usual.
Okay, may I have a motion for approval of the vouchers?
So move, Linda.
Linda has moved. May I have a second?
Second.
Okay, Dr. Edwards has seconded. All those in favor?
Aye.
Aye.
Opposed? Okay. Joe just went blank, but I'm having a real unstable internet today because of a storm going through. So if I blank out, someone needs to jump in. So Dwayne, if Joe's
Sure.
not there, do that,
Yeah,
please.
I seem to be emotionally stable today.
I'm here. I'm here. I don't know why it can't be seen, but
Okay. All right. And looks like Vanessa is coming in. Okay, I understand we have two resolutions that were sent out. So Nikki?
Yes, so this first resolution is contract with KK Zoo LLC. This is a web developer based in Kalamazoo that has created and maintained products that we already use, such as communicable disease reporting for schools. We are working to have a tool that functions similar to school reporting for infectious diseases, but this would be a tool that businesses could use to report any illnesses to the health department, so that businesses have a way to track illness in accordance with the executive orders, and that they would be able to see their trends. There would be dashboards and everything for a business to be able to use to track employee health. But then they would also provide some additional surveillance information to the health department about just what are some trends. There would be no protected health information that would be collected. It would all just be aggregate totals from different employers, and obviously would be voluntary, but we think that there would be a lot of value add to both the businesses as well as public health. So this would we've been in conversations and some of the design thinking through with KK Zoo. This would be a contract that would run through August 31st, and not to exceed a total of $7,670 at a rate of $65 an hour. So again, this is a developer that has worked on a very similar product. This would be now another adaptation for business.
So Linda, you have a question?
Okay, so just so I'm clear, who would this tool be available to, and would there be a cost to do so?
There is no cost, and it would be available to any employer. I was saying business, but it's really broader than business. It's to any employer.
Okay, perfect. That's great. That's helpful. Thank you. Well done.
Training would businesses need to have? Would you do a webinar? And then I think Bill has a question.
So the planning was that it would be it's a pretty simple interface that we're looking to design, but there would be some materials. There would be, we're thinking about potentially doing some video that would help get some training, but the goal is to have it be as simple and easy as possible. It will not have value to workplaces if it is not extraordinarily simple and streamlined.
Did you have a question?
Yeah, a couple of them, if I could, please. First, standard question. why aren't we bidding this? There is a good reason, I'm sure, but I'd like to have that in my mind.
So this has been working through the sole source process that has been a little bit bumpy with our interim, or it hasn't been bumpy, but because we've had the interim county administrator we want to talk about, I know this is so we do want to go to him as sole source, but because this is a parallel product to something that we already use with a similar platform, it's just expanding the businesses that it goes to. It makes sense to go with that same vendor.
Okay, that's good. Thank you. Secondly, is there anything proprietary in this, or who's going to own this product since we're paying for the development?
Courtney, do you remember like who owns the product? The business owns.
So we, like the data it's collecting is all aggregate data. So it's no like identifiable information. The company would own the product, we would own the data. I think that works.
I don't know whether that really, did that address your question, Bill?
Partially. I mean, I assume this business will use this stuff that they develop with other counties and other employers, and et cetera, et cetera, et cetera. I guess for $7,000, if we can get it first and use it first, that may be worthwhile. But if we're going to pay for the development and then they're going to go out and make money off this with 24 other counties, I'm not sure that that's necessarily the best financial model.
Historically, we haven't done real well with these startup kinds of things. We had a problem earlier a couple of years ago.
Yeah, I think this is a little different than, I think we're probably talking about inspected. And this is a little different than that, where we already utilize the same platform for all of our school communicable disease reporting. And that is something that's actually used across local health departments in the state. And so it is, yes, this is something that health departments could potentially use as well. I do think as part of that sole source and it being a similar it's kind of an expansion of that same platform. This developer is giving us the same rates that we've paid since 2010 and making sure that this is that they understand public health communicable disease reporting. And I think that's to this tool being successful.
Well, I guess the question remains, if this is going to be used by a number of different people, are we going to be compensated to join and use it? I don't know.
Yeah, I cannot attest to the business model or what other customers this developer might have that would utilize the portal. I'm not sure.
I suspect it would cost a great deal more, excuse me, if the health department were to go out and try to develop this on their own without, I have no way of knowing how much it would cost, but I think because I'm looking at other applications for other functions at the organization, and this $7,000 seems to be pretty much it. I believe the one I'm looking at was paid for to be developed by someone else, and then they are they're selling it, but you could conceivably ask for a reduction or some sort of a discount for being the first person, perhaps. But I think the reality is that we're going to have to pay for whatever work goes in to developing this and implementing it for you.
Joe, do you have a perspective? Joe, do you have a perspective? Yeah.
No, I think Bill's comment and what just said was, you could always can always ask the question of, could we get a rebate or some sort of, if it is more widely used and they're charging other people, but.
So,
Question.
Well,
I'm sorry, I have a question too, when you're done.
okay, Vanessa, do you have a comment?
I just have a question. I was just wondering if the state had something like MICR for communicable diseases so that communicable diseases could be tracked. Does the state have anything like that?
So there is a communicable disease reporting system. It's called the Michigan Disease Surveillance System, MDSS. And that is where all confirmed cases of report or suspect or probable, there's certain case definitions for all reportable diseases in the state of Michigan go. So that is used very actively in our department and across the state. And it's an instrumental partner, COVID case investigation and contact tracing as well. What we don't have in place and what we would like to do with this system would be to track more of the people that might be symptomatic, might be missing from work because they had a fever or a cough, or it seems like they were symptomatic but didn't quite meet the threshold of a case, maybe didn't get tested. We know that with influenza and many other things, not everybody seeks healthcare. The same is true with COVID. Not everybody, although there is a push for people to be tested if they're symptomatic, we know that that's just not the reality. And so what this would do would give us some additional insight as to where are some of those pockets of potentially symptomatic people. Is this the early warning system for, hey, we're seeing a lot more COVID-like illness, flu-like illness in this part of the county or in this area, to be more of that sentinel of what's going on that we could see and respond to sooner than if we wait until we see only the confirmed cases or the hospitalized cases. And obviously this would be really instrumental if and when we do get a larger second wave, start seeing more of a resurgence of cases, which is predicted in the fall.
I can
go ahead, Linda.
add a perspective. I'm looking at if, how, when we reopen congregate meal sites at senior centers. And there is clearly quite a bit of risk involved in having groups of seniors come together for lunch. And I think that this would be a really good tool to use in tracking the senior centers and activities at senior centers and what's happening. And I'm not sort of picking on senior centers, but this is something that I'm looking at, and I know that they're trying to reopen slowly and carefully, but it would be, I think this would be really helpful, at least for us, probably also for the senior centers. In addition to the companies and the health department.
Bill, a comment?
Yeah, I guess, through this discussion, it appears that this is going to be a valuable tool, and the sooner we can get it moving and finalized and out into the employer population, the better off Berrien County is going to be. I guess for that reason, I'd say we really ought to go ahead and not worry about the downstream economic cost or benefit. So let's just get going with it and help our employers, or as Linda says, senior centers or others, churches who might be able to use this to track their own problems.
Mm-hmm. Since there's been an amount of discussion on this one, is there anyone else who wants to say anything before I call the question? I'd like to take this one separately. Normally we do the two together, but anything before I ask for a motion?
Well, this is going, is the question that we're using taxpayer money to develop something that we use in a private for-profit business? Is that the issue?
Yeah,
Yeah, that's what I thought. I mean, this is always the issue with government funds, from the federal government to the county. But, if this is an essential need for the public, has real opportunities to make our citizens safer, the amount of money doesn't seem overly significant, but I understand the issue.
well said, Dwayne.
Yep.
I'd like a motion, someone to make a motion for approval, please.
So moved.
Okay, Vanessa has moved. Is there a second?
I'll support.
Okay, Joe is supporting. Is there any discussion? All in favor?
Aye.
Aye.
Opposed? Okay, motion carried. Yeah, I can see for the churches, this would be fabulous.
Yes.
Oh, my goodness.
Exactly,
Yeah.
exactly. Any place there's a large
Mhm.
gathering of people.
Mm.
So,
Particularly, yeah, the vulnerable. Yeah. No, that's great. Thanks for your initiative
Yes.
to find this and work it through. So, okay, so a change in staffing, family program staff.
Yes, and so I'm going to pull up a slide here. So what we're proposing in this resolution is we'd like to create a family program manager position to replace our current family health program supervisor. So I've got the org charts up here. The way our programs in this part of the department are currently situated, Courtney oversees not only, but part of the family program section. Courtney oversees the family program or health program supervisor, which is currently filled by Keena King. And Keena oversees 4 staff members, a health educator, 2 MyApp case managers, and a health program specialist. Under her complement is Triple P, MyApp, FEMUR, and CDR, which are some smaller community coalitions raising up healthy babies. TPIP, there's a lot of family programs here. And then NFP is over here, reports directly to Courtney as well. As the program complement change under this supervisor has grown through the addition of some new grants, and really as we've been expanding our work in being trauma-informed, resilience-informed, and rooted in equity, there are a lot of those things that have been falling under Keena as the family health program supervisor, and sort of within the complement of these programs, but then some other add-ons as well. Given the needs of the department, particularly with the way that program complement has changed, in addition to just some of the increased need for responsibilities and bandwidth for Courtney in her role as deputy health officer, it really makes a lot of sense to move to this structure over here, where we elevate the supervisor position into a manager. And then the NFP program will start under this manager as well, so that at the manager level, there's really the coordination of a function area instead of the supervision of a few discrete programs. We really feel like this more adequately describes and also compensates that employee for the work that happened. So in this that is happening and ongoing, and really for the future of our department needs to continue to grow. So this resolution would be adding the family health programs manager and deleting the family programs supervisor. The dollar difference here is in the range of $6,000 to $8,000, and that is something that we feel confident can be worked within the current funding for these programs. Take any questions.
Hi, this is Ray. Can you hear me?
Hi, yeah,
Hi,
right?
I'm sorry, I'm a little bit late. I had some technical problems this morning. Real quick question. What prompted this? Is it just trying to reduce the workload off of Courtney a bit? Or is it with everything else going on, again, loading up more projects on Courtney and trying to get a better coordination of everybody downstream of Courtney on this?
So this has been a direction we've been moving, and you probably don't recall because it was 2 years ago, but when we initially created that family health program supervisor role, reached the NFP coordinator, we were driving in the direction and had, for the future in our minds, we wanted to have the family health programs manager so that that became a more robust service area within our department that really had that function of how do we serve families better. So in the intervening time, we have sought and been awarded additional grants to add more activities to doing that function. And this seems like the appropriate time, given the work that we've been building towards with resilience, being resilience and trauma informed, as well as our work with health equity, some of the coalition work that has been happening in this area. And we really have needed to have a manager position there to really be at the appropriate level for what we've been asking the supervisor to work at. It does seem that this is the right time because that's the direction we're moving. That is the continuing needs that we're seeing in our community with a lot of the changes in how people are living with economic changes that have come from COVID, some of the inequities and social determinants of health and how that has been, the needs there have continued to shift and evolve. This really seems important. So knowing that that was the direction we were going and also understanding how some of that role is shifting in other places of the department, including Courtney's role, this does feel like the right time to me to make change. But this is not a new direction. This has been a next step that has been planned since we did the reorganization.
Thank you.
All right. It seems like a logical thing to do. Are there any other comments or questions, or Dwayne, do you have anything?
No, I'm fine. I'm fine.
Okay.
Craig,
Bill?
some of the pushback that this is going to receive when it goes to us is we say this is the right time to do it. Well, adding more cost in the budget and promoting people when we don't know what the future is bringing, I think will be perceived as the wrong time to do something. The second thing is that the health department has always prided itself on being a very flat organization with very few leaders and many hardworking people. Not that leaders aren't hardworking. We're adding a level of hierarchy here. And I don't know. That's something for this board to consider, and I guess everybody's good with it, and I'll support it. That's to the commission level, but I think there's some philosophical things that may be at issue here.
So, I mean, I hear exactly what you're saying, and I appreciate that insight. I do believe that this leads to an appropriate span of control without adding extra layers of hierarchy or things in a way that are unnecessarily adding layers to that.
Any other board thoughts or questions?
Well, it's, did I hear you say it would be increase of $600 to $800? Did I hear you say that?
6,000 to 8,000.
6,000 to 8,000, okay.
Well, I'm an advocate of flat organizations as well. I guess as I glanced at this, I didn't see it as a big expansion of the span of control because I think flat is better generally, but I don't have a problem with it.
All right. Any more questions or comments from the staff? Anything you'd like to say, Courtney?
No, I mean, I think Nikki pretty much said that. It's something we've been working through for a couple of years. I think that this really unifies our family health program area, which has been our goal to ensure that we have that cohesive service. I think that this then starts to be a little bit more balanced with the rest of our departments and our manager representation there, and that gives better support overall to these programs. And truly, this evolution from supervisor to manager is, I think, more reminiscent and honoring of the capacity that has grown in those programs, with additional work that's come underway with like our Taking Pride in Prevention programming and fatherhood support work that was not there, prior. So it's a more accurate representation of the workload and the responsibilities for this position.
Maybe
Okay.
based on Bill's comments, maybe this is something that is a good idea, but as Bill's saying, maybe not the best time to be presenting this to the county, and hold off on it for a few months or so until we see what all falls out from budgets at the county level based on COVID costs.
Wonder if you do present now, I think you need to have a very, very robust backup for the benefits it will provide to clients, and perhaps not in addition to benefits to staff. But I think that you may get some real difficult questions, and I think you need to be prepared to make a really strong case in order to get it through right now.
Comment, Monday.
Joe, did you have a comment?
No, I was just supporting Linda's comment. I thought that was well thought.
So I guess that this is kind of the perception is this might be a very risky thing to do at this point.
No, Peg, quite the contrary. I think it's something that at this point in time, a lot of commissioners are going to grumble about the finances, but trust in the health department's decisions here. Because the health department is number one in Berrien County right now. It's just down the road when all of the bills come home to roost. Are we going to have to start taking out jobs? And if you're taking out jobs, you're going to take out non-work, wrong word, in the field functioning type jobs. So, but I said I will fully support this if this is the will of the board and we can get it done now.
Okay. Anyone else like to comment? All right. I'd like someone to make a motion for approval, please.
So moved.
Okay, Vanessa has moved. Is there a second?
Second.
Okay, so Joe has second. Any discussion? All those in favor?
Aye.
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 Anyone opposed? Okay, motion carried. So certainly understand why you're doing it. So, all right, moving on. Nikki to financials.
Yes, so I believe you've received the financials in your packet. Not gonna go through in a ton of detail in Lisa's absence. The bottom line is that we are still doing okay. There have been a lot of extra expenditures due to COVID. We know that, but we have received a grand total of about $300,000 from the state, which has helped offset a lot of those additional costs. And we have had reductions in spending in our typical programming, which has provided a bit more margin in some of those programs as well, because we have had all of our trainings canceled and there has been less field work. So reduction in travel and supply line items as we've continued to see in the March and the April statement. So at the end of May, really at the bottom line, we're about 5% total under budget, with a proportion of that is coming from salary and fringe, and that is an area where we do tend to be under budget. Right now, we're at under budget about $76,000 for salary and fringe for the year. And we have, in the month of May, reflected in the statement, we have brought on 1 or 2 contract temporary staff members. So we're continuing to watch that and what's happening. We do expect to receive and have received general notification that health departments will be receiving some additional funding from the state for the purposes of case investigation, contact tracing, isolation needs, and other infection prevention activities in our community. We do not have a dollar amount yet, and we have been told that it will be a funding cycle of approximately 30 months, so 2.5 years, but it will be significantly front-loaded. So we are expecting still sometime this week, but maybe next week at this rate, since we haven't heard anything, to receive an amount about that. So we'll be, as soon as we have notification, we'll be bringing that to the commissioners for their acceptance. But so right now, since we're in the last quarter of the fiscal year for our grants, we're just continuing to watch, make sure that we are appropriately spending down all of the grants and seeing where that shakes out. Even though this has been a highly unusual year, getting through September 30th with where our grants are, we do feel like we're in okay shape. There are a lot of unknowns, as we alluded to in our last discussion. There are a lot of unknowns come October 1. The state has started that budgeting process, and we've been given some very preliminary numbers, but we think they're subject to significant change. But we do have about 6 weeks before we need to have that first contract, the comprehensive agreement, signed. So there will be more communication at our next meeting about how that is shaking out. So I don't know if there are any questions specifically that I can answer, if that was enough of an overview.
That KKZO contract be part of the new funding, or would it not be, would it be not eligible?
It would absolutely fit as part of that new funding. It would also fit under some of the funding we have already received. So it would be eligible extended either of those buckets.
Okay.
Nikki, I have a copy of the fiscal year 2020 budget agreement for the Corona Relief Fund's second release. And for the state, it looks as if public health emergency response funds will be $648 million across the state. So unknown what Berrien County will get, but
And unknown what local health departments will.
I know, no, I understand that, but that's a pretty nice, I mean, statewide, that's a pretty nice dollar amount.
Absolutely.
I didn't have any breakfast either. Ben's already been there and he's so fun, such an entrepreneur.
All right. Is there a conversation going on that I can't hear? Sorry. Okay. Are there any questions on the financials? That was a good report. All right. Moving on to the health department, couple reports. I'd also like to add at the end, if you would, your plans for staff review, if we could include that in the health department section, please.
Absolutely. So similar to what we've done for the last couple of months, there's not going to be very clean lines between Dr. J, Courtney, and I. But Dr. J, I know you want to talk about some of the data and trends. You want to get started?
Sure. So just a quick update on data trends and some of the data in the news, and a little bit of in regards to children, which I think is pertinent in the fact that schools are going to be reopening. In Berrien County, we still have about 950 cases, 60 deaths. We've had new deaths in about a week now, about 8 or 9 days. We have 2 people in the ICU. I believe both have been for a while. No other hospitalized COVID patients, all in Lakeland. In Michigan, remember we have a population of 10 million.
Dr. J,
Yes.
could you come closer to a microphone, please?
I thought I projected better.
Yeah, blow back.
Michigan has 10 million population. We have 70,000 cases. We have 6,000 deaths. I'll just set that in perspective because we keep hearing about these soaring huge numbers in many states like Texas, Florida. Can you hear me good now?
Thank you.
So in Texas, they have triple our population and they have way less than half our deaths. They have only about 40% of the deaths we have, and they have triple our population. Same thing with Florida. They have more than double our population. They have way less than half our deaths. And remember, both of these states have been wide open. The media keeps saying how the numbers of cases in those states are just soaring and going crazy and elevating unbelievably. Well, why is that? Some people describe it as a paradox of the number of cases and then so few deaths relatively. Of course, I'm not saying any death is acceptable or we don't like deaths, but the numbers are really astoundingly different in terms of the number of cases and the number of deaths. So why is that? So one thing is for sure is the number of people being tested is incredibly expanded, and the number of young people being tested, whereas the number of young people in many places, including Texas, used to average an age of 65 to 70. Now the average age of a tested person in Texas, for instance, is 30. So we're testing a hugely younger population, and we're also testing tons of worry well. People who go in are concerned they might have it, are asymptomatic, who end up having a positive test. And they may have had an asymptomatic case weeks before. Another possibility is that temperature. I still think this is a factor. A lot of people do. In warmer environments, the size of the inoculum people get is lower. So that's probably a reason why there are less people getting seriously ill. There also is the theory that keeps being discussed and studied is the virus attenuating a little bit? There's no clear proof that that is true, although there's constantly looks for that. So that's just some of so when you see all these numbers about how terrible it is in Texas, and Joe, the CEOs down there all got together in Houston where they had been reporting how packed their beds were, et cetera, and they had to come back and apologize because they had realized they had inflated their numbers and had not included beds that were potential ICU beds that they could use. And by the way, of all the ICU expansion that's happened there, less than 23% of the people in ICU beds in the major Texas cities have COVID. The vast majority of the people are the people who couldn't get to the hospital or were afraid to go to the hospital earlier and got worse because they didn't take care of problems sooner. And that's been clearly articulated in a number of medical articles that people are waiting too long when they have stroke-like symptoms, heart disease, and a host of other problems, and then end up really, really sick, and that's who's in there. And then so just looking in terms of, we all know, of course, that long-term care unit people are still number one. Nationwide, it's well over 40% of all the cases. And that includes the fact that the number one state for deaths is New York by far, and they don't even count them correctly. They don't even count their LTCU cases well. And so the number is actually far higher than that. In our cases, in our county, 70% of them are LTCU. All of our cases have at least 2 more comorbidities, and 50% of them have 3. Now, looking at children, for example, children data is hard to come by, but I asked several very astute people recently, how many people do you believe have died, from nationally from COVID? And they're hard numbers to get, but they're coming out. Under 25, what would you guess would be the number of people that have died under 25 in the entire United States from COVID? So we've had lots of numbers, but the number is, I know you're all new, but the number is 160. That's 2 weeks ago. Think about that. That's a very low number. How many kids under 18 years old died in 2019, 2020 from the flu? 188. So think about those numbers a little bit and put them in perspective when we think about schools. Florida has done the best job of tracking kids in terms of COVID. So 9.2% of the tests that have been done in Florida involve kids under 18. They've had 100 hospitalizations. 80 of them have been newborns readmitted. They're the at most risk. They have had no deaths, not one death in the entire state in any kid. Similarly, in New York, there's an article in New England Journal of Medicine this week. New York had about 5 deaths. The CDC is reviving some of them down. 2 of them were the Kawasaki-like syndromes, and a couple of them don't even qualify for that syndrome anymore after a study that's been conducted. So when we look at schools, we have to consider again how low the risk is to children in terms of getting seriously ill from it. And I think we have to keep presenting that. And to me, just like we talked originally about the vulnerable populations, we have to be careful, of course, for teachers and staff. And that should be the goal of what we're trying to take care of in school. And that's what we're going to be working with the schools here coming, I think it's Tuesday, right? So Tuesday, we'll be meeting with all the school superintendents. They're very happy about it. We're both digesting the 63-page report that Nikki was very involved in. I'm sure she'll talk about it some. But so just keep that in mind when we're talking about children. Teachers unions are pushing back from statements by the American Academy of Pediatrics and others that school has to happen. There has to be in-person school. And they list a whole series of things that are problems that are happening because school has not happened. And that's my report. Thank you.
Questions for Dr. J?
Yeah, Rick, I appreciate the info. Right now, the thing that's concerning us at Lakeland is the concept that we may have to shut down elective surgery again and elective services, which you and I have shared many conversations on. And I appreciate the clarity of it. I hope the tone, though, isn't that we should be less diligent about mask wearing, less diligent about social distancing. There's a segment of the population that believes that we should just say to hell with it and go to herd immunity philosophy. So could you clarify clearly what your position is right now on the mask wearing, how aggressively we should be promoting this from the health department? Because I don't want to minimize the seriousness of this. Fauci wasn't fooling around yesterday when he said we could be looking at 100,000 cases a day. And it's not just because we're testing more people. So could you give us some info on that?
So personally, I probably would support parents' right to choose as being done in most European countries on whether they mask or don't mask. I think teachers should be protected. There should be a shield like in Ace Hardware and stuff like that in front of teachers. I think that in the younger elementary grades, vulnerable older teachers need an aide in the classroom who's younger to be able to help hands-on stuff with kids. I believe the teachers should be masked, and all those things can happen. Personally, I would be for parents' choice of whether they mask their kids or not. And that's what's being done in Europe. However, I'm not going to go out and say I disagree with the state's plan. If that's what the state's plan is, of course, that's what I'm going to follow. And I guess out of an abundance of caution, it may make more people happier. Is that a fair statement?
Yeah, well, I would say parents' choice, though, is, parents aren't the experts. And so I was talking more broadly about society, less than in the schools.
Okay.
I think it's going to be very challenging to get a first grader to wear a mask. But I was talking more broadly in societal recommendations because it is extremely frustrating. We've done a very good job in healthcare of, making our patients wear masks when they come into the office. We've been very compliant within the health system of mask wear, but I'm sure, as all of you have experienced, it's extremely frustrating when you go out to any retail store, you go out to any food establishment, the belligerence that some people are demonstrating when it comes to mask wear. And I'm wondering if you could clarify your position on that and, those of public health officials in the state.
Yeah. So yeah, my comments earlier were related to school. I thought you were asking about, the school thing. Yeah, I mean, I think that the social distance, wearing masks, when I see people wearing masks while they're driving their car, or as a neighbor's doing, putting a mask on a kid riding a bicycle down the street who's not wearing a helmet, these things seem like absurdities to me. But in closed spaces, wearing masks is a very reasonable thing, and I think businesses should encourage people to do so. How they actually carry it out, I think in part is up to them. I don't know how we can be policing all of that. There are things though that seem like a racket club that can't play tennis indoors, and things like that just don't seem to make any sense to me where there can be social distancing. If there can be social distancing, then I think mask wearing is less of a dramatic effect.
So if I could
Yeah,
add to that.
Sure.
So some of the ways that I've been thinking about this and some of my comments feeding into the Return to Schools Advisory Council, which were sort of incorporated in the document to some extent, it almost feels like there's this triangle of mitigation efforts that on one corner, we've got face coverings. On one corner, we've got social distancing, and on another, we have cohorting or limiting contact between people. And depending on the different situation, different sides of that triangle are going to matter more. And you always get the best impact if you can layer on multiple of those three. But there's a little bit of give and take. So if you can do the social distancing, the face covering, to Dr. Day's point, matters a little bit less. If you can't do the social distancing, the face coverings matter a lot more. If you're going to be around the same three people all the time, just like with your household members, for example, because not everybody is been trying to isolate from household members. Whatever you opt for, the small number of close contacts, then some of the other stuff may not matter because there's that balance and calculus of how to actually do life with the people in your life. So it's those three that are really important. And I think for people who don't have a lot of experience in infectious disease and droplet transmission of viruses, it can be a little bit more difficult to think through which parts of the triangle of those three things to lean on and to really do that. So a lot of our technical assistance that we've been providing to workplaces and other just community groups is trying to understand how they can think through that triangle a little bit more, because we can't set out a piece of regulation or guidance for every specific scenario. Although I do believe that the guidance that is coming out from public health officials is trying to help people lean into the right part of the triangle in the right situation. It is far from perfect.
So I think when you look at the confusion, and I think this is the absolute role of the Board of Health and the health department right now, there is developed, and I think belligerence is the right word, that has developed politically. And this has unfortunately become a political issue where some people think that it's politically sound to be defiant and to comply with recommendations. Your explanation of the distancing versus the mask wear, et cetera, is spot on. I guess my point is this: we need to continue to realize that we're going to have to be very educational in this process, because people are drifting. And when you look at what happened at the Harper Bar up in East Lansing, and if you've been in other establishments, that's a lack of understanding. It's a lack of the bar owners being compliant. And we're developing this political conflict that's going to get in the way of health. And I can tell you that if we see cases significantly rise in Berrien County, that we're going to see the reduction of health services, elective health services. That is indisputable. So I appreciate the clarification there. The school issues are interesting. Today on the front page of the paper, St. Joe superintendent's talking about having the online option again. There's going to be a lot of parental education that's going to be necessary before school starts. And Rick, any thoughts on interscholastic sports?
Well, the current, Nikki would probably say more about that than me, but the current plan is that sports are going ahead. They're going ahead with sports. And baseball tournaments are actually happening right now. There was a big one in St. Joe the other day. There's traveling teams going as far away as Indianapolis. There was one down there last weekend. So sports are happening. MHSA is supporting it cautiously.
Right. So the state roadmap for schools is giving deference to the Michigan High School Athletic Association because they do have some really good guidance and recommendations out for schools to follow. I do believe later in the month of July, there might be some decisions made about maybe switching seasons of sports to try to see if there's something we can't do this fall. Maybe we could do it in the spring with some optimism there that things might be better then. So
There's a lot of unknown at the moment. Yeah. It's a fair statement.
All right, if there are no more questions, you want to
Okay.
continue with the, yes, Linda?
Can I ask, my concern when school resumes is that I know one of the real conversations among seniors is when can I see my grandkids again? And so it's not just the children, it's not just the parent. It's a whole nother generation or two of possibly very vulnerable people who may be coming into contact with a child who has suddenly come into contact with 20, 30, 40, 50 other children in a public environment. And it just sounds as if you're focused on the children, but well, the family can take care of the family. And, to Dr. Edwards' point, if you see another spike among seniors, it may not be the seniors in the nursing homes in the fall. It may be the seniors who are caring for their grandchildren or being close with their grandchildren. And I think that needs to be part of a conversation.
And so I will say that it absolutely is part of the conversation. And one of the reasons why I personally am very much in favor of face-to-face instruction in the school is because I think it will actually minimize the amount of mixing that children do compared to virtual or some sort of hybrid schedule. The schools do have the authority or the ability to make a decision to do virtual learning or a mix of in-person or virtual. But when we stop having the Monday through Friday full day schedule, children are then more likely to be placed in some sort of after school care or some sort of other thing where they're mixing with students outside of their typical building. They're not in the same controlled environment that the schools will be with implementing health and safety measures. And there may be more grandparents that are called upon to watch children while parents are working. And so when we think about spread in totality, which is absolutely how we're thinking about it, not having students in school does pose, I believe, more transmission risk just because there will be more mixing of relationships. And there is room in the public health code, and this is how we definitely treat with infectious diseases, and this is how we were preparing to address COVID before the executive order shut down schools across the state back in March. But there's ways to determine, is the school presenting a public health threat to the community? So not necessarily a threat to the students or the staff in the building, but does the presence of children aggregating in that manner represent a transmission risk that spills over into the broader community? And we are absolutely monitoring and taking all of those things into consideration, to your point, Linda.
Thanks for serving on that committee, Nikki. It just seems like you as a staff haven't gotten a break, and that's just an additional thing that you're doing, and just really appreciate your statewide leadership.
Thank you, I appreciate that. So to keep moving us along, so as you mentioned, again, we will continue to work with schools. There are a lot of things that in that roadmap that are being left to local health departments, and collectively health officers across the state. We're working to now figure out exactly how we're going to address those uniformly, but still in a way that is able to take into account local factors. So some other things I just want to mention about COVID-19. If you've been following our data for the last couple of weeks, and to what Dr. Johansson was saying, there has been a significant slowdown the last couple of weeks in cases. We've actually had days where we've received no reports of new cases over the last couple of weeks. So that has been a positive. Our rates of testing have remained fairly level. We're not seeing necessarily a decrease in testing. We're seeing a decrease in that percent positivity. So that has been good. We were watching, but over the last 4 days or so, we have started to see the numbers of confirmed cases start to go back up, where we're seeing over the last 4 days, we've seen anywhere from 4 to 8 cases per day, which is nowhere near where we were at the height of this, or in May. But we're continuing to watch. Is this just a few-day aberration? Is this just a little blip? Or are we starting to see a little bit more of that increased activity? We're not seeing hospitalizations increasing or deaths, as Dr. J said, but there is sometimes a little bit of a lag. So we're as you know, we're continuing to monitor those things. One thing that is really encouraging is we're not really seeing many new cases in nursing homes. Transmission in long-term care facilities does seem to be slowing down, which is really, really good news. Our long-term care facilities have done a tremendous job of trying to either prevent COVID-19 transmission before it gets in, and we do have some that have not had positive cases amongst residents. But then once it's there have been a lot of really wonderful efforts to slow and stop that transmission, and we're seeing a lot of the fruits of that labor right now, which is a wonderful thing. So that's very positive. I want to transition us now to talk a little bit more about what the health department is doing over this last month or so. We really have opened up more of our services, and staff are being increasingly pulled between their normal job duties and those functions that we need to keep going. As the earlier conversation between Dr. Edwards and Dr. Johansson was indicating, there are a lot of things that it was okay to press pause on for a short period of time, but it's now been long enough. So we are really resuming a lot of things, or scaling up some of our activities. So I'm going to turn it to Courtney to talk about that a little bit, as to some of where we're at in terms of operating, how we've modified some of our programs. It won't be exhaustive, but to just give you a little bit of an overview.
Yeah, so I think we talked about this, gosh, all the days run together, but a board meeting or two ago, maybe 2 at this point. But it's been really important to us throughout this whole thing to have good continuity of operations. And as Nikki said, different weeks and months, depending on the needs surrounding COVID response, we've scaled that up or scaled that back. But we have never just stopped and only had that one train line. And I think that's really important, and is a testament, 1, to our staff, and 2, just to our overall department focus to really be focused on community need and that trauma resilience lens, and understanding we can't just remove everything and focus on one thing, right? That has impacts to our community. So
Courtney, I'm going to ask you to come closer, please, because you're kind of zipping in and out. Thank you.
Oh, this is low.
Thanks, Courtney.
No problem. So what that means for the department right now is, here at the beginning of June, so through May, we started to slowly scale up. June, we really scaled up a lot more. What that looks like is all of our clinics are operating at this point. So sexual health, so family planning services, STD services are operating. WIC is operating. These services operated in duration, but they had a little bit more of telehealth touch points or limited provision of services, just so we could continue to keep those touch points as short as possible. We do have all of those services now active. We've tried to maintain the virtual telehealth options. We still just have families who are not comfortable in person, and we want to make sure that that's not a barrier. But we have others who that just has not been a good way to connect, and they really need to come in and have their services here, see a provider. So that is all now happening. How we're doing that is by appointment only. So if you'll remember, pre-COVID, we did have some walk-in options. We had a little bit more fluidity in how our clinics could operate. Right now, we are doing by appointment only, working with community members to schedule those appointments when they work for them and have them come in. What that allows us to do is ensure we have good appointment spacing. What we don't want is to have a full waiting room. We also don't want people to get backed up and have to wait longer than necessary for an appointment. So we're really working on when someone arrives at the department, they're able to get right in for their service and then head back out. One, protecting our clients and also our staff. And so as a department, we also have a daily health screening. So all of our staff, we've been doing this now for a few months, but do a daily health screening using the website application that Lakeland promoted early on. So we're continuing to use that each day. Staff show that to supervisors or screener we have at the front door. All of our clients, when they enter the building, we do also a short health assessment just to ensure that people are not visibly actively sick at that time. We ask for hand washing there as well as wearing a mask. And so if a client does not have a face covering upon entry, we do have those available and we are providing them while they're here for their service. So those are some of the ways we're doing that. Other areas of the department, we are back doing all of our home visiting services, that as well as a hybrid. So we had been doing all virtual touch points. Now we're still maintaining a lot of those virtual touch points, but in some of those higher need families or a mom who just delivered and might need something, that touch point, we're trying to evaluate that on a case-by-case basis and really ensure that we're supporting our families and continuing to build that relationship. There's a lot of that just stress and need in the community, and we want to make sure that we're attentive to that. So that's continuing hybrid. Some of our families just feel more comfortable still having that virtual connection. And again, we're going to maintain that when we need to. Other things, so environmental health are incredibly busy. It's summer, so they are out on beaches and we are doing our vector surveillance. The nature of a lot of our environmental health services, luckily they can be outside in fresh air. So that's a good thing. We are of course doing restaurant inspections and continuing to do that. We've kind of mentioned this throughout, but we don't want to have a foodborne illness that we have to work through while we're responding to COVID. I think one of the biggest things that in June the one thing that we had stopped except for 24 months and I think 2 month ends, we had really stopped doing immunization for the first few months. And that was really because our nursing staff were all hands on deck with case investigation and contact tracing. However, as was alluded, we cannot stop those services forever. So since the last week of May, we have been doing immunization clinics, working to kind of build some of our capacity to get people caught up and do some extra opportunities there. And so again, that follows all of those clinic procedures to ensure people are here for short amount of time, have the health screenings. So that's kind of the overall thing. All of our services are operating, albeit some of them still virtual. We're not bringing together big groups of people. So a lot of our advisory boards and coalitions are meeting virtually. We're getting really good at Zoom meetings and being able to facilitate in a Zoom space. And we'll continue to do that and just evolve as we go. All of our programs that are on the field have some specific guidance just to kind of continue to do some of that education and review with our own staff. I think Dr. Edwards, you alluded to this, it's an ongoing process. We have to keep making sure that that's at our forefront of washing hands and appropriate PPE, and how we are presenting to our public is also an example of how we want our public to interact with each other. So really making sure that we have those protocols in place. I think that's the overall. Anything that you guys would add that?
Yeah. So the other piece to that too is just our response team. As we've talked to you, we do have our incident command structure that has been stood up and are continuing to work through that process for COVID-19 response related activities. We do our briefings just a couple days a week now. It's still important that we maintain that structure and that organization to that response. It's just some of the lines are starting to get a little bit blurrier as which type of activity is this? Is this day to day? Is this COVID? And some of it is blending. And I do expect that blending will continue because COVID in response to it will be with us for a while. We are doing whatever preparation we can and thinking about what mass vaccination looks like. We do have mass vaccination plans, so we're brushing up on those, making adjustments as required. It's always good to review those plans. The state is doing the same for their mass vaccination plans, but we are definitely looking forward to the point, and we don't know exact timing, but we're looking forward towards when there will be a vaccine available, how that distribution might go, and what that might look like at that time. So we're doing that forward thinking and planning right now. Some of the other things just internally, and Peg asked me to talk about staff reviews. So typically we do performance reviews for all staff across the department in the April to June range. Because this has been really hectic, people haven't exactly been in their doing their normal functions during that time, and the leadership team has had a tremendous burden. We have pushed that back, and we'll be doing that in Q3 of the current year. But we're continually just shifting. What are some of those normal activities? What are those things that we know we need to get done, and maybe it's not the most urgent thing, but it continues to be important. And how do we arrange that, and where do we put that? So. My hat's off to Courtney. She's done a fantastic job leading a lot of that coordination for our continuity of operation planning and continuing the shift, because it's not a one and done activity. It is an ongoing need.
In terms of a question of vaccines, one of you asked me, actually two of you asked me about vaccines and when you think they might be. I think they might be ready. There's two huge trials going on right now that have just begun. And if you look at the timing of those, I think October, November is a reasonable time frame that we can expect some vaccine rolling out. And there are three main kinds of vaccines being developed. One is the very well genetically engineered little teeny piece of RNA, almost like a hepatitis A vaccine or a HIV vaccine, which would have, like all of those, virtually no side effects. And if it's effective, would be great. Moderna is one of the companies working on that one. That's entering big trials. And then there's lots of kind of vaccines in between. There's one that's derived, they're actually growing the virus in chimpanzees and using that instead of an egg for like flu vaccine, they're using chimpanzees to grow virus particles. So that's another end of the spectrum. Obviously, I think that first one, the little genetic piece, would be the one to really go for, October, November. Remember, when vaccines happen, who will be done first? First people will be done will be long-term care unit workers, hospital employees, Ken Edwards, and all the people on the front line. So the people being done first will be a little bit further down the chain, and then we'll be moving into all vulnerable seniors. So in terms of mass vaccinations of the general public, that'll be a ways away from a production standpoint.
I had a question about catching up with vaccines for students getting into school, particularly, and just how are we going to do that? I know you've done some clinics and things, which probably, what are you going to do?
So we're hoping to have, we typically have the back to school bash, which is a very large event that draws a lot of people, and it provides that opportunity and has become increasingly popular over the last few years. Obviously, that type of format, even in August, we do not expect would be feasible. So we're discussing what those plans look like, but trying to see how can we maybe do pieces of that over time, and really have a push for getting parents in with their kids. There will obviously need to be some collaboration and communication from schools about that as well. The other thing that there will also be a need for with school children is hearing and vision screenings. Those are required for entering kindergarten. Most children get those done in a preschool setting in the spring, but that didn't happen this year. So we've got a couple of those sorts of activities we're really pushing for. We have brought on at least one temporary nurse who's assisting with case investigation and contact tracing, and it was really important to us to make sure we were able to get some nurses so that we had more hands that could do vaccination. So the short answer to your question, Peg, is we're still working on exactly what that's going to look like, because we also anticipate needing to make sure that the flu vaccine gets out there quickly and early this year as well. So those plans are still coming together, very important need.
Peg, I have a question.
Mhm.
The COVID impact on schools, I know that the minority communities, and I know in Ohio, I don't know if it's projected in Michigan, but they're looking at split days possibly so they can have social or distancing between their desk. And with the online, it seems that minority communities that don't have the family support are going to face some difficulties, and school systems already are subpar, potentially could even become much more compromised. So I presume that these groups that are meeting are taking that into account.
Yes, I do believe that that's on the radar. I don't know that anyone has a great answer, but that is part of the reason why the My Safe School roadmap that the governor released yesterday does not create mandates for social distancing in the classroom, understanding that most school buildings would not be able to accommodate that without some sort of split schedule or half virtual hybrid model. Knowing that's not feasible, especially across the board, that technology and access to Wi-Fi is also varies widely. And again, like you said, with home support for doing virtual education, it just really is across the board what students' experiences are. And there was some intention, I don't know how successful any one policy ever is in doing this, but there was some intention of how do we not further perpetuate some of the issues that our most distressed schools are experiencing.
So the little kids tend to be the germ bombs, and so if they tend to be aggregated like that, then go home to crowded living conditions where their extended family probably has some of those multiple issues, is that going to create a community situation that we need to be concerned about?
Well, I agree with kids being germ bombs for lots of things, but that does not appear the case to be the case with COVID. It appears that it's harder for kids to get it, and they don't spread it nearly as well for a variety of reasons, which would be a long conversation. But kids handle this virus differently. They don't carry it as much, and they don't spread it as much. And since most of them are asymptomatic, they're even less likely to spread any size inoculum. So that the germ bomb thing fits lots of things, but probably not COVID in kids.
Have you opened Three Oaks for services, or does that continue to be closed?
Yeah, that's a great question. I should have covered that in our continuity. So all of our offices are now operating, and that's been as of the last week of May. Our Niles office, we had dropped that to about 3 days a week just for a little bit. That is now open 5 days a week. And then in Three Oaks, it's about a day and a half, 2 days of clinics that are happening there. So yes, all of the offices are operating.
Okay, great. Do you have any family planning materials in Spanish for the Three Oaks office? Okay, you do. Okay. I've been working with a number of families in Three Oaks. If you wouldn't mind sending me that, I'd be most appreciative.
Great. She will do that.
I would like to propose to the board as well that we do your review, Nikki, in the third quarter as well, so that we just get on that cycle. So what we've done in the past is Nikki and I have worked on goals. We've reviewed them together, and then we've had a closed board discussion about Nikki's performance. I'm proposing that as a way to go. Any thoughts or suggestions?
That makes sense, Peg. There's a lot on the table right now yet, so obviously don't want to forget about it. Keep it up in front and center, but putting it off a little bit until third quarter makes sense, or through the third quarter sometime.
All right, so I see some head nodding. All right. So that was the staff report. So we're at 9:18 in the morning. Do you want to talk about program, Nikki? Moving on.
Yeah, so the last thing that we really have for you in just highlighting some of the work that's happening here at the department is wanted to just bring you an update. We haven't talked about our Kreisky work that Courtney and I started, gosh, it's been about 2 years now. And we still have some of that grant funding that we've been trying to figure out how to use for workforce development here in 2020. This has just been a bit of a wonky year, as you know. But one of the things that we wanted to highlight is that part of that work is that we created the IDEA team. And we've talked about that with this board before. IDEA team stands for Inclusion, Diversity, and Equity Advancement. So this is a team of staff members from across the organization. We have representation, I think, from all of our functional areas, including environmental health. And we have people from all levels of the organization, from senior leadership to frontline staff. And so this group has formed about a year ago and has spent a lot of time working to understand health equity with a structural lens and understanding trauma and resilience, and really how to do public health with those lenses and with that framework, because that's not something that is traditionally how a lot of programs have been implemented. There has been a push moving in that direction, and so this team is working to help push our department further along. So there was definitely a level of a few months of foundation building and some training and some education with the members of these teams, or this team, as well as with all staff with some of the trainings we held in the fall that we've talked about. Right around the start of the new year and in the winter, before everything really got messy with COVID, the team was working to analyze different policies and procedures that we have in the department with that trauma, resilience, and equity lens to really determine where we as a department could continue doing better and where could we improve, what were some areas that business as usual is not aligned with where we're trying to go with this equity frame. So there were some things underway. Some of the stuff that we had talked about was about hiring and recruiting and how are we what steps we're taking to ensure a diverse workforce that reflects the people being served, and how are we valuing some of those things, as well as building broader staff capacity. So during COVID, some of that work was really put on pause because there just was not enough time and bandwidth to devote to that. In the last 2 months or so, that group has really gotten back together, and in the last month or so, given a lot of things that have been happening with different community partners and just the social narrative on how does equity impact our lives, how do inequities impact all our lives, where's the work to be done, and with more and more people looking for a structural lens to understand how day-to-day events impact our lives, and ultimately what we're concerned about impacting health. The group has really been doing a lot. So there's continuing to be some capacity building things that are coming out of that group. The group is looking for how do we partner with some of our other organizations. I'm sure some of you have seen that Lakeland has taken a really bold stance on working to address health inequities. And this is work that we've been doing together as organizations for quite some time, as you all are aware, as Lakeland is continuing to level up with that and make that a lot more public. There has just been continued talk of how does our how does our department continue to push forward with our initiatives, and how we deliver services and how we interact with the community in ways that really build towards that health equity agenda, especially as other health partners are continuing to push that agenda forward. Courtney, what would you like to add to that update at all?
I think the only thing that I would add is, and I know, so we had been working on addressing some of those more internal policies, practices. Nikki said with 2020 just being the year it's been, that certainly had to look different over this spring. And I will say the IDEA team has been really instrumental in, while some of that work wasn't able to move forward in the same way, helping drive some of the work and foundation of how, as a department, we were serving and showing up for our vulnerable populations during this COVID response period, as well as how we were showing up for our own staff. So this team has kind of that double charge, right, of how we are infusing equity work internally as well as in how we show up externally. And so this team really was able to help give some of that feedback and drive some of that work as well. So I think a lot of the foundation setting over the last year allowed them to be able to serve in that advisory and guidance capacity, which was really great. And many of those team members really stepped up to lead some of those outputs for vulnerable population touch points and ensure that we were ensuring equity in our response work. And I think that's really important to note from the team's involvement too. And certainly they are all department team members. We all have full-time jobs while we're here, but really rising to ensure that they're integrating this into their own work and then working with each other. So that's been a really great part of bringing this IDEA team together, I think, is that kind of joint cohesion of addressing equity together.
We very much look forward to your products. Hopefully in August, things will be calmer or calm down to have a robust discussion of it. It's really important to me, and I hope to the board as well, to discuss.
If I could, I'm sorry, Peg, if I could ask, as the newest member, anything that you would recommend for reading would be appreciated. To sort of learn more about the issue. I read a lot about health equity and health inequity, but if there's anything specifically that you would recommend that we read and become familiar with, I'd be appreciative.
Well, if it's something you would all be interested in, when, I can't remember if this was pre your joining or not, Dr. Edwards, I apologize. But Nikki and I were able to share last October with some of our fellow public health departments at the Premier Public Health Conference. And at that time had kind of put together a roadmap of how we put a foundation together for our own internal IDEA team. And so there's certainly lots of things we can read, but if you would be interested in it, I would be happy to share that document that just shows some of the documentaries and the videos and the articles that as a team we dove into together, that really help show the history and some of those structural inequities that we're seeing play out. So I'm happy to share that with the board.
Yeah, why don't you do that again? That's good.
Yeah.
Okay. Questions, thoughts before we have Bill unmute and tell us what's happening on the Board of Commission? And I also would ask about the salary study. Is that done? Just curious. You need to unmute, Bill. Please unmute. Bill, you're muted. There you go.
Nope, still muted.
Hold on, I'll unmute him.
Just a second. Okay, now you're unmuted, Bill. Thanks.
Great. Technology is a wonderful thing. Couple of things you mentioned, Peg. Brian Doucette, our new county administrator, starts today. I think he's already had some meetings, Nikki, with some of your folks as a kind of an introduction.
He was able to come by here last week for about 20 minutes. So we briefly met.
All right. Well, I may suggest to Brian sometime in the next few months, if this board ever gets together in person, that he come out and get a chance to meet everybody. But he's going to go through a learning curve here for several months. The question, Peg, about the salary study, we have received a draft report from the consultant. And I have a copy. I may be the only person that has a hard copy. And there's still some significant questions out there, but we're a lot closer to what we need. I am trying to coordinate a meeting with the consultant to have him come in and present his findings to the committee on committees, which are the heads of the organization, the different subcommittees, along with Jillian and a couple other people who were key people from the staff that we had on our team, to present this, talk about it, and then develop a plan for moving forward to take it out to the organization. So it's there. I'll just broadly say that there's a lot of people who maybe are not not compensated as well as they should be. And that's across the county. No surprises. So we will have some challenges in this challenging environment on how to do that. So more to come on that. Is there anything else I could address, Peg? I'm forgetting.
No, that's what. So do you have any preliminary budget ideas, or have you heard
No.
anything? No.
We're a long ways away from that. There's going to have to be a lot of difficult internal choices for sure, because we can't pay for what he's suggesting we should, at least not immediately. So everybody is going to have to make some difficult choices on where to make change.
Any questions for Bill?
Peg, I have
All
a
right.
question. I'd like to ask a question, maybe going back to Nikki. I mean, Andrews is sending out a lot of stuff to students about, coming back, the processes, testing, the social isolation. I guess I want to make sure that they're coordinating this with you guys in the health department, Nikki. I mean, the president tells me they are, but I'd like to hear it from you. How are you guys involved with their communication about what students should do, the protocols you're going to be used at Andrews?
So I don't believe we've been directly consulted to the extent that you're describing. I know that there have been some more general communications with Andrews along with many other stakeholders. I'm not sure to the details of the extent. For us administrators in the room, we have not been as involved in those. And I don't believe our business liaison position has been doing that. So we're available to the extent that it's helpful for organizations, and if they can follow the guidance without us, that's okay too.
Well, I want to make sure, because I mean, Andrews is the place that'll bring in the most people from the most places in about 6 weeks.
Yeah.
So I want to make sure they're coordinating with you. I'll check with our president to make sure that they're doing that and who they're doing it with.
Great.
I could make a comment. I know in looking at reopening our congregate meal sites, one of the challenges is that I am informed that I have to follow CDC, MyOSHA, and local Berrien County Health Department regulations. And guess what? They don't always sync. So I'm trying to tiptoe my way through all of that and err on this on the side of safety, but it's a pretty interesting process.
I imagine.
All right. It looks like, Jillian, that I need to, if there are no more comments, to adjourn the meeting, and then if there are any public comments, to address them. Is that correct?
I have one question,
Uh-huh.
if I could, just a concern with Whirlpool's announcement of spending $280 million to this year to reduce staff. So there's going to be significant job cuts. Whether we need to think about the impact our community, the health system, retail stores, real estate, the impact on school system, downstream unemployment. It seems like it's a big deal, and I don't know what impact that will have on tax revenue, all sorts of downstream impact on the community. Something to think about.
Yeah,
So absolutely. This is COVID fallout.
Mhm.
Well, if I could just, having been through 5 or 6 of these in my career, this is not an unusual occurrence. It's coming for an unusual reason, but big companies like Whirlpool have an accordion effect on their employment levels. And because the market is down and their stock is down and their profits are down, the accordion is being squeezed. And I think your comments are well placed, Joe. We've got to be ready for it. But Whirlpool takes care of people in these unfortunate situations fairly well. And I think there's going to be a good safety net for the number of folks that have to leave the organization.
All right, any other comments before we adjourn?
There are 2 public comments on YouTube thanking the board for making this meeting available, as well as for the commentary regarding wearing masks in public.
All right, thanks, Jillian. If there's nothing more, thanks for everybody's participation, and the staff preparation was excellent. Thank you. We stand adjourned.
Thank you all. Have a good holiday.
Thanks.